So I'll be talking about the link between venous thromboembolism and atherothrombosis. This is an association that has only recently come into focus, and I'm glad that I can share it with you. So over the next 20 minutes or so, I hope to review shared risk factors for venous thromboembolism and atherothrombosis, to highlight the common pathophysiological pathways in venous thromboembolism and atherothrombosis, and then finally to emphasize the importance of an integrated approach to the prevention of VTE and atherothrombosis. VTE, including deep vein thrombosis and pulmonary embolism, is the third most common cardiovascular disorder after myocardial infarction and stroke. An important link between VTE and atherothrombotic disorders of heart attack and stroke has recently been recognized. There is a reciprocal relationship. Patients who have suffered deep vein thrombosis or pulmonary embolism have a high risk of developing heart attack and stroke after their diagnosis. Conversely, patients who've had a heart attack or a stroke have an increased risk of suffering venous thromboembolism. In this seminal paper by Prandoni et al., atherosclerosis of the carotid artery in the neck is associated with an increased risk of venous thromboembolism. In this study, I'd like us to focus on these two lower lines on the graph. These are lines for patients that are aged 20 to 39 years. The bottom line is patients who have not suffered venous thromboembolism, and this upper line is patients who have suffered either DVT or pulmonary embolism. And this is the risk of having a heart attack. And we can see in these young patients, patients who have venous thromboembolism have an increased risk of suffering a heart attack. Here we can see that in patients who've had either deep vein thrombosis or pulmonary embolism, there is an increased risk of heart attack or stroke that's highest in the first 5 years, but continues even 15 years after their initial episode of venous thromboembolism. And this increased risk of heart attack and stroke is present if patients had a provoked venous thromboembolic event or if the event came out of the blue. So we have to abandon silo thinking when we consider venous thromboembolism and atherothrombotic disease. We can no longer think of VTE, heart attack, stroke, and peripheral artery disease as separate orders. Instead, we have to consider them as a spectrum of diseases that can coexist in the same patient and that reciprocally increase the risk among these diseases. Now I'd like to focus on individual risk factors. We know that the risk factors for atherothrombotic disease, heart attack, and stroke are shared with venous thromboembolism. Risk factors of stress, tobacco use, the metabolic syndrome, high cholesterol, obesity, high blood pressure, diabetes, diet, and hormones all contribute to an increased risk not just of heart attack and stroke, but also venous thromboembolism. In this figure, we can see data pooled from many different studies. We know that obesity is associated with an increased risk of heart attack and stroke, but from this pooled collection of data, we can see that there's at least a twofold increase in the risk of venous thromboembolism in patients that are obese. High blood pressure is well recognized as a risk factor for heart attack and stroke. But from these data, we now realize that there's at least a 50% increase in the risk of venous thromboembolism in patients who have high blood pressure. Diabetes has not traditionally been recognized as a risk factor for venous thromboembolism. But these data suggest that there's a 40% increased risk of venous thromboembolism in patients who are diabetic, and from other studies we know that this risk persists whether patients have type 1 diabetes or type 2 diabetes. While total cholesterol does not appear to increase the risk of venous thromboembolism, High triglyceride levels and low HDL levels increase the risk of venous thromboembolism. I think we all know that smoking increases the risk of heart attack and stroke, but it also is an important player in venous thromboembolism. An increasing number of cigarettes smoked on a daily basis results in a greater risk of venous thromboembolism. The metabolic syndrome is a risk factor for cardiovascular disease that has only recently been recognized. It represents a constellation of disorders including abdominal obesity, high blood sugar, high triglycerides, low HDL, and high blood pressure that significantly increases the risk of heart attack and stroke. It's also been shown to be important for venous thromboembolism. Here we can see that the metabolic syndrome is associated with a significant increase in the risk of venous thromboembolism, especially in men, and that most of that increased risk is due to abdominal obesity, which is the distribution of fat around the trunk or abdomen. Interestingly, we can see that when you look at abdominal obesity alone, it's also a very significant risk factor for VTE in women. Diet is very important for the prevention of heart attack and stroke, and it also matters for venous thromboembolism. A diet rich in fruit and vegetables is associated with a reduction in the risk of venous thromboembolism. High intake of red and processed meat is associated with an increased risk in venous thromboembolism. Hormonal factors are important. Hormonal contraception and replacement therapy have been linked to heart attack and stroke. Oral contraceptives, especially those containing third-generation progestins, increase the risk of venous thromboembolism. And in the Women's Health Initiative, women receiving estrogen and progestin hormone replacement had a twofold increase in venous thromboembolism. We all know that stress is bad, and it's bad for heart attack and stroke, but it also matters in venous thromboembolism. There's an increased risk of any kind of venous thromboembolism in patients who have persistent stress in their life, and this is especially true for pulmonary embolism. Now I'd like to focus on pathophysiology. So we spoke about how the risk factors between venous thromboembolism and atherothrombosis are shared. Obesity, high blood pressure, tobacco use, high cholesterol, diabetes, diet, stress, and hormone replacement and contraceptive therapy are all important considerations in the risk for venous thromboembolism and atherothrombosis. But there's more than just shared risk factors. There are pathophysiological processes that are shared between these two diseases. Inflammation, hypercoagulability, and endothelial injury all play a role in the pathophysiology of venous thromboembolism and atherothrombosis. We know that inflammation is important for the development of heart disease and stroke. A marker of systemic inflammation, a blood test called C-reactive protein, is associated with an increased risk of heart attack and stroke. But from these data, we now know that it's also associated with an increased risk of venous thromboembolism, suggesting that inflammation on a chronic basis plays a role in the pathophysiology of DVT and pulmonary embolism. Hypercoagulability, or a tendency to have blood clots, is an important consideration. Diseases like anticardiolipin antibodies, presence of the lupus anticoagulant, and hyperhomocystinemia are associated with both venous thromboembolism and atherothrombosis. Other hypercoagulable disorders of factor V Leiden, the prothrombin gene mutation, and deficiencies of antithrombin, protein C, or protein S are mostly associated with venous thromboembolism. Endothelial injury, or the injury to the vessel wall, is very important for the pathophysiology of heart attack and stroke. but it may also be a very important factor in venous thromboembolism. In this study, investigators looked at the effect of lower extremity injury on the development of venous thromboembolism, and what they found was that injury to the legs, whether or not immobility was present after the injury, was associated with an increased risk of venous thromboembolism. That suggests that it may be more than just immobility when one injures the lower extremity, but perhaps local trauma to venous structures that increases the risk of venous thromboembolism. Now I'd like to talk a little bit about prevention. Prevention really needs to focus on lifestyle modification, control of diabetes, reduction of inflammation, in appropriate patients, prevention of venous thromboembolism, treatment of high blood pressure, anticoagulation for certain patients, and then treatment of high cholesterol if we're really going to prevent both venous thromboembolism and atherothrombotic disease. Lifestyle modification needs to include weight reduction, exercise, increasing fish, fruit, and vegetable intake, and decreasing red meat consumption, tobacco cessation, and then stress reduction. We've learned some important lessons about inflammation from the Jupiter trial. The Jupiter trial was a large randomized controlled trial published in the New England Journal. The trial focused on patients who had no cardiovascular disease that was known, really normal cholesterol levels with an LDL cholesterol of less than 130, but signs of systemic inflammation with an elevated C-reactive protein. And these patients were randomized either to receive a statin drug, rosuvastatin, or a placebo. And what was found was that patients who received rosuvastatin had a reduction in the risk of venous thromboembolism. While there was no difference in the risk of unprovoked venous thromboembolism in patients receiving rosuvastatin, there was a significant reduction in provoked venous thromboembolism. We know that statin drugs do more than just lower cholesterol. They're important inflammatory modulators. And so I think these data really support expanding our understanding of the pathophysiology of venous thromboembolism to include inflammation. The Worcester VTE study is a large registry of patients who have suffered venous thromboembolism from central Massachusetts. And we've analyzed these data to get a better understanding of the risk factors that patients with atherosclerosis have for venous thromboembolism. And what we found is that patients who've suffered venous thromboembolism and have atherosclerosis or history of atherothrombotic disease, heart attack or stroke, have a high frequency of other risk factors for venous thromboembolism, namely immobility, heart failure, chronic lung disease, stroke, and chronic kidney disease. We would have expected that with all of these risk factors, every patient with a history of atherosclerosis who was admitted to the hospital for medical illness or surgery would have gotten some prophylactic measures to prevent venous thromboembolism. We were surprised to learn that more than a third of patients with atherosclerosis did not receive any preventive measures when they were in the hospital for either surgery or medical illness. These data raise very important policy implications that I'd like to discuss. We talked a little bit already about the U.S. Surgeon General's report. The U.S. Surgeon General estimates that 100,000 to 180,000 pulmonary embolism-related deaths occur annually in the U.S. alone, and that pulmonary embolism is the most preventable cause of death among hospitalized patients. Venous thromboembolism complicating hospitalization for medical illnesses such as myocardial infarction and stroke burdens the healthcare system. Identification of individuals with atherothrombotic cardiovascular disease provides additional targets for VTE prevention efforts. Medicare has classified deep vein thrombosis and pulmonary embolism occurring after total knee or hip replacement as never events, and has stopped reimbursing hospitals for the additional costs incurred by this complication. It's conceivable that a similar policy could eventually be applied to VTE complicating hospitalization for myocardial infarction and stroke. With that, I'd like to leave with a few take-home points. Common risk factors, including obesity, poor diet, smoking, link VTE to atherothrombotic cardiovascular disease. VTE and atherothrombosis share critical pathophysiological mechanisms of inflammation, hypercoagulability, and endothelial injury. Preventive efforts need to avoid silo thinking and should emphasize lifestyle modification and focus on risk factor optimization.